Okay. I'm provided with the SWI diffusion weighted.
Okay, I'm just telling you the sequences. This is a DWI ADC. This is T2 axial, T1 axial, T2 sagittal. This is axial flare, and this is again the cis sequence, which is dedicated for nerves. So just to save time, because it is already a case which is going to take some time.
Okay.
There are subtle findings, but it is an important diagnosis, and it is missed a lot of times. So it is not only going to help you in exam, it is going to help you in practical life as well. There are few features in these images which will help you in narrowing down your differential. And just focus on the history again. This is a 43 years old female with headache.
Okay, ma'am. There is no abnormal areas of diffusion restriction or ADC in the temporal lobes and the cerebellum. And on the T2 weighted image, globes appears unremarkable, and there is a abnormal T2 hyperintense signals identified in the suprasellar region, and it is giving fluid density on the T1 as well, with internal dot of hypointensity on the T2 and hyperintensity on the T1 weighted images. And
that is insignificant, that dot. That is basically infundibulum, which is projecting within the cellular region.
Okay. Ma'am, in the last image, within the globe, there are concentric hypointense bands. These can be the...
These are artifactual.
Okay. And then...
These are not seen on T1 and T2. So when you perform cis sequences, you can get these because it's a volume-based sequence. So because of the physics of the machine, you can get these artifacts.
Okay. Ma'am, there are no abnormal signals in the brain parenchyma. The flow words of the sinuses appears intact. And
so up till now, you have picked up one finding, that there is fluid signal intensity in the region of sella. Right?
Yes. Yes. And
so what is that? That is an empty sella.
Okay.
That is an empty sella. Do you agree?
Ma'am, there's a hyperintense focus.
It is basically an empty sella, and the hyperintense focus which you are looking at is the infundibulum, and it is giving altered signals. It is insignificant. Just don't focus on that. There is an empty sella. This is one finding. Find some more areas.
The pons, there are subtle abnormal signals in the medial temporal
lobe. In the pons. Nothing in the medial temporal lobes.
Okay.
Focus on the optic nerves.
Ma'am, the course of the left optic nerve appears to be slightly
on T2 and on this cis sequence. Can you see some extra CSF in the perioptic sleeve? There is slightly tortuous course of optic nerve, and there is increased fluid in the perioptic sleeve. And if you focus on these images, there is subtle diffusion restriction in the optic nerves. They appear low on ADC map. Can you appreciate that?
Okay. Yes, ma'am.
So now, since I have told you the finding, what is the diagnosis? There is empty sella, there is increased optic neuritis. Why will there be empty sella and optic neuritis? Okay, focus on these sequences, this sequence. If you look at the optic disc head, can you see a slight bulge here? Can you see this slight bulge here?
Yes, ma'am. Very subtle.
Okay, so The findings are subtle, but the symptoms are actually severe. Can you see that the patient is very obese and there is a lot of fat at the nape of the neck?
Yes, ma'am.
So now can you reach to some conclusion? So this is basically a case of benign intracranial hypertension, which is idiopathic in obese females, especially from 18 to 45 years of age. It is 1:8 times male is to female ratio. And the patient presents a severe headache. There is swollen optic disc head. There is restriction in the optic nerve. There is increased perioptic sleeve. There is empty stella. There is thinning of the ventricles, red light ventricles. These are all very subtle features. If you see here, there is increased fluid along the optic sleeve, right?
Okay, ma'am.
So this is basically a case of benign intracranial hypertension. What you have to look in this case is empty or partially empty stella. We saw here, there is posterior globe flattening. There is intraocular protrusion of the optic nerve head. Optic nerve sheath enlargement plus tortuosity. Optic nerve head diffusion hyperintensity. Slit-like ventricle, which is rarely seen. And we perform MRV in these patients to look for chronic venous sinus thrombosis, because chronic venous sinus thrombosis is one of the causes of raised intracranial hypertension. It is one of the causes of secondary intracranial hypertension, in which you have to look for chronic venous sinus thrombosis. Different medications cause this. There can be certain medical conditions which can result in this. But if you can't find any of these conditions and you exclude all of them, and the patient is obese female, then you have to look. You have to label it as benign intracranial hypertension, and the opening pressure of CSF in these cases is raised. So the next investigation is opening pressure of CSF, and the best imaging tool according to StatDX is MR brain plus T2 coronal fat saturated orbits plus MRV. This is T1, this is T2 axial, this is flare axial, post contrast T1 diffusion ADC, and post contrast coronal. So give me your findings.
I can see abnormal MR signal intensity area in the region of brainstem, in the region of brainstem, a CP angle that is ISO on T1, hyper intense.
Intraaxial or extraaxial?
Extraaxial lesion, madam. And
extent. It is
extending into the internal auditory meatus as well.
Diagnosis bata dein.
Schwannoma, madam.
Differential.
Vestibular schwannoma. Meningioma.
ठीक है, बिल्कुल सही है. So it's a vestibular schwannoma, and then meningioma comes in the differential if you don't see its extension. This was basically a case referred to us for cyberknife. And the patient had 2 scans over a span of 3 months. Initially, it was labeled as schwannoma from one center. Later on, from another bigger center, it was labeled as a meningioma. So our oncologist was really confused at which one is this. For that case, you have to look at its extension into the internal auditory meatus, and that is actually the problem-solving, statement. So you have to look that there is extension. Ji.
Madam, if we are unable to recognize the sequences easily in the exam, would that cause a problem, or will our marks be deducted for that?
Yes, it is very important. Yes, that will. जी बिल्कुल, क्योंकि ये basics है ना. You should be familiar with basics. Recognizing sequences is the basic thing. Because if you will not recognize the sequence, how will you pick up? For example, they are showing you a T1 weighted axial, और उसमें वो आपको लाइपोमा दिखा रहे हैं और आपको पता ही नहीं है कि ये T1 है और T1 पे हाइपर इंटेंस या ब्लड होता है या फैट होती है. So how will you make your diagnosis? So it is very important to recognize sequences. It is very easy, especially in brain. So it's so easy. आपने 3 चीजें देखनी है, gray matter, white matter और CSF. And on the basis of that, you will decide कि ये जो है वो T1 है, T2 है या flare है. और diffusion ADC में तो वैसे ही you can't see the anatomical details, so you get to know that this is diffusion. उसके साथ ADC बनाया ही होगा, तो 2 इकट्ठे ही दिखा रहे होंगे सेट में. Then comes the susceptibility. मस्कुलोस्केलेटल का भी सेशन आएगा, तो आई एम श्योर कि वो आपको इस पे आंसर करेंगे, लेकिन वो भी बहुत डिफिकल्ट नहीं है. मैं आपको एंड में अपना ईमेल एड्रेस दूंगी, आप मुझसे डिस्कस कर लेना बाद में आफ्टर दिस सेशन. ठीक है. सो दिस इज इन 8th nerve schwannoma or differentials will be meningioma. So the reporting tips or the exam tips which you are supposed to answer So it's a T1, T2 and 2 coronal images at the end. Just tell me the findings and what do you think it is in 30 seconds.
Okay, on the axial and the coronal sections, I can appreciate that area of abnormal intensity signals involving the posterior parietal, temporoparietal region with central hypointense on T1 and peripheral hyperintense signals. On the T2 weighted images, it is showing homogeneous hyperintense, and on the flare sequences, it's also showing hyperintense signals. I'm not provided with the post-contrast images. So considering the findings of central hyperintense on T1 with peripheral hyperintense signals, this likely represents a mass lesion, which is showing hemorrhage at its periphery. It is also causing effacement of the ipsilateral adjacent ventricle and slight effacement of the sulci. On the provided.
So basically, this was the patient. It's fine. You already described these findings, so we will just move on quickly because there is a dropout, and then there is a false diffusion restriction due to hemorrhagic products. And then this area is redemonstrated on T2 as well. You have to age the hemorrhage. In exam, they can ask you about the different ages of hemorrhage. That is important to know for your exam purpose. You should ask in the history, whenever there is a lobar hemorrhage in an old patient, you should ask about the history of hypertension. If there is history of hypertension and it is a typical location of hypertensive bleed, like in the region of basal ganglia, you will consider hypertensive hemorrhage. But when there is no history of hypertension and there is a lobar hemorrhage in an old patient, then you have to consider amyloid angiopathy. The imaging recommendation in this case is a T2 star or a gradient echo sequence, or in highly sophisticated machines, we have a susceptibility weighted image equivalent to that. So in all elderly, we should perform that as a protocol in our department. We also perform that, and I would recommend everyone to add this to their list. This is an axial graphic which is showing acute hematoma with the blood fluid level at times, because there are various bleeds of various ages. There can be multifocal microhemorrhages in amyloid angiopathy. Diffusion ADC, susceptibility weighted images. Then we have T2, T1, post-contrast T1, axial and sagittal. So we can see an area of lobar hemorrhage here as well. But there are few features which are different from the previous case. You just explained those, especially the post-contrast images.
On the post-contrast images, the left parietal region is showing peripheral enhancement.
Peripheral as well as central, heterogeneous kind of enhancement.
Yeah.
Okay.
Yes, it's almost complete ring of enhancement, and with central areas of enhancement as well. And
then there are associated herniations. You can see that along this tentorium, there is some descending tentorial herniation. So it is important to mention in your report, because it's basically, uncle herniation is basically an emergency. So you have to mention it. Similarly, there are some flare hyperintensities in the leptomeninges posteriorly. So this shows that probably there is some subarachnoid component. There is an associated small subdural component as well. So when there is enhancement in a large hemorrhage, what will you consider? What will be your first thought?
It's hemorrhage within the mass lesion with malignant.
It is hemorrhage within the mass lesion. So this patient gave a history that patient had some kind of weakness 1 week back, and at that time a CT was done which showed a hypodense lesion. So when the lesion was hypodense at that time and now has hemorrhage in it, means that there was some mass lesion which has bled now. Right? So previous imaging is very important. Taking hold of previous images are very important. We will consider hemorrhagic mass in this case. We will consider primary versus secondary, and we will first work up for the secondary, so that we will first work up for the primary lesion, and after that, if we can't find any primary in rest of the body, we will go for histopathology. This is a female patient, so we will first consider breast, and we will go for mammography. So the diagnostic checklist according to STAT-DX is that spontaneous intracranial hemorrhage in the elderly may be caused by metastasis. White matter diseases in elderly can be caused by multifocal metastasis. Consider T1 contrast plus in patients with white matter diseases. Unexplained mental decline. ADC, T2 and T1 weighted images for you.
There is a well-defined area noted in the medial occipital lobe on right side, or posterior medial temporal lobe. It is basically on the right side, and it is not showing any diffusion restriction. It appears hypointense on T1 and T2 with a rim of hyperintensity on T2. I can appreciate a isointense nodular area in the anterior part of this lesion.
Okay.
I would like to see further images on FLAIR images. There is a demonstration of this low intensity area with surrounding hyperintense rim on coronal FLAIR and T2 weighted images, and on SWI it is showing signal dropout.
अपना differential बता दीजिए.
Okay. This may represent a aneurysm of a posterior inferior cerebral artery.
ठीक है. पेशेंट का CT angio normal था वैसे.
ठीक है. और उसके अलावा
it's a good thought to consider.
Apart from that, this may be a hemorrhagic lesion or a calcified lesion. So
कैसे कंफर्म करेंगे? हमारे पास ससेप्टिबिलिटी का वो फेस डायरेक्शन वाला तो इमेज है नहीं, यही है सिर्फ SWI. तो अब हम कैसे कंफर्म करेंगे ये कैल्सिफाइड है या हेमरेजिक है?
मैम T1 पे like a bright arrow, लेकिन basically phases of hemorrhage. T1 पे भी लो है ये.
क्या करें हम?
पोस्ट कंट्रास्ट देखेंगे मैम.
CT देख लें आप.
क्लासिफिकेशन के लिए.
कैल्सिफाइड क्या बन गया?
मेनिंजियोमा हो सकता है इस लोकेशन में. उसके अलावा ये
अब आप मुझे ये बताइए जो आपने पीछे देखे हैं, डू यू थिंक इट्स एन एक्स्ट्रा एक्सियल लीजन और एन इंट्रा एक्सियल? यहाँ पे तो ये प्योरली इंट्रा एक्सियल लीजन है. इसके बाहर हमें नजर आ रही है ग्रे मैटर ना दोनों जगह पे. एक्स्ट्रा एक्सियल नहीं है ये लीजन, इसलिए मेनिंजियोमा तो नहीं हो सकता ये.
ये ट्राइगोनी वेंट्रिकल में नहीं है.
वेंट्रिकल के अंदर नहीं था ये प्रोजेक्ट पूरा. ठीक है. तो व्हेन यू सी कैल्सिफाइड इंट्राक्रैनियल लीजंस, दिस आर बेसिकली नेम्ड इन लिटरेचर एज कैल्सिफाइड इंट्राक्रैनियल स्टोन्स का नाम दिया है उसने लिटरेचर में. डिफरेंट 6 से 8 केसेस की कोई एक केस सीरीज है in which they have said कि 2016 में कोई AJNR में पब्लिश हुई है, and they said that if it is more than 10 millimeters, so we call them calcified intracranial stones, and when you find them, your approach should be that is it intraaxial or extraaxial? If it is extraaxial, then you will consider it as an osteoma, bone based है, or a dural based like meningioma, arachnoid से जो आता है. If it is intraaxial, then you have to consider either it is a vascular lesion, neoplastic lesion, infectious, congenital or metabolic. So probably it is a calcified cavernoma because इसके बहुत popcorn like margins हैं. But until unless we get the histopathology, we cannot be sure of. But you should be able to pick up the lesion, its signals, and then you should be able to have a certain approach that is it extraaxial, intraaxial. This is ADC. ये जरा आगे पीछे लगते हैं. DWI ADC T2 T1 coronal flare. ठीक है. ये भी T2 है, ये susceptibility है, और ये हमारे पास T1 post contrast है. ऊपर नीचे प्लेन और पोस्ट कॉन्ट्रास्ट है. जल्दी से 10 सेकंड्स में अपनी फाइंडिंग्स बता दें.
मैडम T1 पे आइसो, T2 ब्राइट एंड फ्लेयर के ऊपर हाइपर इंटेंस एरियाज सीन इन लेफ्ट पैराइटल एंड बाइलेटरल ऑक्सीपिटल एरियाज, एंड on post contrast this shows peripheral ring enhancement and
any multifocal lesions है.
peripheral enhancement.
क्या लोब्स आपने बता दी लोकेशन क्या है इनकी?
जी मैडम.
क्या ये कॉर्टिकल बेस्ड हैं? क्या ये वाइट, इनकी लोकेशन क्या है? क्या लोकेशन लोब्स के हिसाब से नहीं, वैसे ग्रे मैटर में है, वाइट मैटर में है, किस जगह पे है?
मैडम कॉर्टिकल बेस्ड हैं ये.
अच्छा, अगर ये कॉर्टिकल बेस्ड हैं तो ये आप T2 इमेज देखें, इसमें तो कॉर्टेक्स ठीक नजर आ रही है.
जी मैडम सब कॉर्टिकल.
सब कॉर्टिकल. ओके ठीक है सही. अब क्या करेंगे इसमें?
मैडम इसके
बेसिकली दीज आर एट ग्रे व्हाइट मैटर जंक्शन।
जी मैडम, ये मैडम मल्टीपल जिस तरह मैडम ये प्रेगनेंसी हाइपर कोएगुलेबल स्टेट होती है, तो इसमें ये मल्टीपल इन्फार्क्ट्स जो हो सकते
मल्टीपल
हैं।
इन्फार्क्ट्स होंगे तो वीनस होंगे ना, वीनस में तो ज्यादातर हेमरेज आता है, इसमें तो कोई हेमरेज नहीं नजर आ रहा। ससेप्टिबिलिटी मैंने आपको दिखा दिया उसी लेवल पे।
जी जी,
मल्टीपल लीजन्स हैं, एनहांसिंग लीजन्स हैं, ठीक है। इन्फार्क्ट की एनहांसमेंट भी गायरी फॉर्म होती है, इसकी एनहांसमेंट तो गायरी फॉर्म नहीं है, तो मैस लाइक एनहांसमेंट दे रही है।
मैडम ये वो एम्बुलाई जो होते हैं वो
एम्बुलाई की जगह क्या होगी, जहाँ पे वीआर स्पेसेस आएंगी ना, एम्बुलाई की जगह तो यहाँ होगी जहाँ पे आपके परफोरेटर्स आते हैं। एम्बुलाई की जगह ग्रे व्हाइट मैटर जंक्शन तो नहीं होती है। ग्रे व्हाइट मैटर जंक्शन पे क्या चीज होगी, मल्टीफोकल। एज को छोड़ दें, प्रेगनेंसी को छोड़ दें, ग्रे व्हाइट मैटर जंक्शन पे क्या चीज आती है
मैडम? डिफ्यूज एक्सोनल इंजरी यानी ग्रे व्हाइट मैटर जंक्शन पे आती है।
एक्सोनल इंजरी आती है, लेकिन उसमें आपके पास ससेप्टिबिलिटी पे आनी चाहिए ना, कुछ ड्रॉप आउट वो नहीं आ रही तो एक्सक्लूड हो गई।
जी मैडम।
एमआरवी भी ठीक है, एमआरए भी ठीक है, आपने जो डाउट दिया इसका। पेशेंट का बीटा एचसीजी जो था वो 1 मिलियन था, 1 मिलियन यूनिट्स, ठीक है। और ये पेशेंट के मेट्स थे फ्रॉम अ कोरियो कार्सिनोमा, ठीक है। ये इसका पेल्विस का एमआर है। सो शी हैड अ हिस्ट्री ऑफ प्रेगनेंसी, शी हैड एक्सटेंसिवली रेज्ड बीटा एचसीजी लेवल्स। उसको 3rd ट्राइमेस्टर में भी शदीद वॉमिटिंग्स थी। जब हमने उसका बीटा एचसीजी लेवल कराया बहुत ज्यादा था, अल्ट्रासाउंड किया उसमें भी मैस आ रहा था। वी कंफर्म्ड ऑन द, वी नीडेड एक्चुअली एमआर पेल्विस तो चाहिए था हमें, क्योंकि हमने स्टेजिंग इसकी बेसिस पे करनी होती है। सो पेशेंट वाज अ केस ऑफ कोरियोकार्सिनोमा, यंग पेशेंट थी और उसके ब्रेन में मल्टीपल मेट्स थे, ठीक है। ग्रे व्हाइट मैटर जंक्शन पे यू आर राइट, डिफ्यूज एक्सोनल इंजरी होती है, लेकिन आपको साथ में मेट्स भी सोचने चाहिए ना। और ये टिपिकल इनकी यही लोकेशन थी जो मैंने आपको दिखाई है।